Welcome to the HL7 Da Vinci Project Community Roundtable and HL7 Workgroup Meeting, Birds of a Feather. We're starting our webinar just a few minutes early to help people joining us from the various corners across the country. So we're just going to hold tight for a couple minutes as people come in from the working group meeting, as well as from the rest of their day, as if they're coming just from the industry perspective. For those who may have just joined, we're going to give it a couple more minutes as people are transitioning from the working group meeting and other meetings to join us. So appreciate your patience while we give time to join us. Good afternoon and welcome to the HL7 Da Vinci Community Roundtable and HL7 Working Group Meeting Birds of a Feather special combined session. Today's session is Driving Change in 2026, Use Case Progress and Preparing for HL7 FHIR Adoption. My name is Alix Goss, and it is my pleasure to moderate today's Community Roundtable and Birds of a Feather session, and to remind all of us that we engage in these forums under HL7's antitrust policies to ensure appropriate collaboration and information sharing. Today's session focuses on sharing a comprehensive update across all of Da Vinci's use cases, implementation guides, and projects that are achieving advancements in standardized data exchange. This session will also highlight Da Vinci's 2026 priorities and the Community Champions Program. We're elated you are with us today in this first-time approach to combining our industry-facing webinar with Da Vinci's Bird of a Feather educational session typically delivered at HL7 working group meetings. Our presenters today include Heras, who's our Da Vinci Project Deputy Technical Director and Principal Informaticist from Optimum eHealth, Lloyd McKenzie, also a Da Vinci Project Deputy Technical Director, and also the Chief Standards Officer at Dogwood Health Consulting, along with Casey Thompson, the Da Vinci Program Coordinator and a consultant with Point of Care Partners. I encourage you all to use the question function in Zoom throughout today's event. So let's dive in because we've got a lot to cover. We will post the recording of today's webinar and slides on Da Vinci's video presentation page on Confluence. Da Vinci's communication lead, Leslie Ambrose, will be posting links in the chat box to assist you with locating that page and other key resources you may find of interest. Please be sure to use the Q&A feature to submit questions, as we've limited the chat features for us to push key details to you and so that you can then download the chat box so you can save those links and have them at your fingertips when you need them. We've also muted lines to aid our recording quality. Finally, we sincerely appreciate your survey feedback solicited at the conclusion of the webinar or at the point in which you depart the webinar. Our community roundtable schedule is fourth Wednesday of the month, typically at 4 o'clock. Our next session is February 25th with a patient cost transparency focus. And in typical fashion, slides and recordings from our community roundtable webinars are available via Confluence and are also available on YouTube. Let's make sure you're aware of key industry events. There is the ASTP, the Assistant Secretary for Technology Policy annual meeting, February 11th through 12th in Washington, D.C. It's a hybrid event with some of the main stage events broadcasted, and the rest of them are in-person sessions. VIVE is happening later in February, the 22nd through the 25th in Los Angeles, during a very busy week of meetings, including the 2026 State Healthcare IT Connect Conference in New Orleans, February 23rd through the 26th. Also happening then is the Weedy Winter Forum happening in San Diego. HL7's next event is May 2026 in Rotterdam. I did learn today that there's the potential for a US-based Connect-a-thon testing event either the last week of March or the first week of April. Stay tuned for more details, but that event will be a virtual event for folks to attend and advance their use case testing objectives. In June in Minneapolis, there will be the FHIR Dev Days event, which are a fantastic event for those who get deeper into the development aspects of FHIR. I'd like to pivot into our program updates and to kick off the year with presenting Da Vinci's 2026 program priorities. These reflect the priorities, objectives from our membership and help us focus our efforts around our three core functions of use case specifications, implementation progress, and members and community supports. Our specific 2026 focus around the development, piloting, and adoption of our implementation guides, or IGs, are to enhance the implementer support for implementation guides named in regulations and to do this directly or through our extensive collaboration with our industry partners. We also seek to foster and stimulate greater piloting and implementer community engagement and shared learnings. This includes the ability to bring more information to you on the stage, enhance our implementation guides, but to also advance our methodologies for stakeholder feedback during the implementation guide development cycles. We would like to explore creative approaches to getting those who cannot afford or have the time to traditionally participate in standards development to get their feedback and perspectives on workflow dynamics and other aspects that may impact our development cycles and the robust usage of our specifications across the industry. Da Vinci's been a project for more than 8 years, and we've assessed the need to establish a rubric for assessing our implementation guide development investments and adoption readiness. This not only helps us with using our membership dollars wisely and where we focus on bringing the most value in value-based care exchanges, but it also will help us with our trajectory across the healthcare ecosystem on identifying the trigger mechanisms for when implementation guide is ready for overall adoption. Coordination with our industry and federal partners is extraordinarily critical. It helps us extend the reach, and it also helps us better support the overall industry need for education, awareness, specifications, and overall adoption uptake to augment and extend our human workforce's capabilities with the tools that are enabled by our FHIR-based specifications. We look forward to continuing our efforts with them and to furthering the reach to support 0057 update for the interoperability and prior authorization rules and other priorities that are emerging from both federal obligations as well as business priorities. Throughout the year, we will continue to monitor and assess implementation guide opportunities and alignment with federal policy response opportunities. continue to heighten the awareness of FHIR, and continue to evangelize and provide thought leadership from our extensive community of members. Our members, as well as the industry, come together to create the heart and soul of the Da Vinci Project. We have a special set of within the community that we recognize as champions who bring unique traits of industry above self, a passion for making the healthcare system better, and commitment to growing others and promoting change. We are currently taking nominations for the champions that should be recognized for their body of work in 2025. So please take a moment and complete our very brief survey for the nomination process. It is open until January 31st, 2026. And I'm confident Leslie will put that link in the chat box so that you can all fill that out if you've got some champions who meet these criteria and really have contributed in a way that deserves recognition. Speaking of recognition, we'd like to make sure that you're aware of the 2024 HL7 Project Community Champions. Kirk Anderson from Cambia, Linnell James, formerly of the Blue Cross Blue Shield Association, Scott Rosignol, a critical part of the eHealth Exchange community and our Trebuchet community at Da Vinci, Jed Van Horn from Multicare Connected Care, Dr. Steve Waldron, who's from the American Academy of Family Physicians and also a co-chair of our Clinical Advisory Council, and Michael Westover, who's from Providence and is also a steering committee member. But all of these individuals have been nominated and have elevated the contributions to a level where we'd like to recognize them as the 2024 Project Champions. And so they will be receiving a beautiful award in recognition of all of their unique traits and contributions. Pivoting from program updates, I'd like to set the stage for the rest of today's presentation by giving you a brief overview of our use case and IG readiness slide, which has gone through some collateral refresh since we last presented it to you. And this is my final slide for today, and I'm happy to share with you the key updates that we've made. First, we've added the implementation guide number below the actual use case name, so that it's easy for you to know the current published version of that implementation guide or use case. The lighter color and the arcs, the half moons around each of the use cases help us understand, first of all, let me explain the maturity level, the color schemes from green, blue to an orangey sort of tan color. So if it's green, it's reflecting most mature. If it's blue, it's an active growth, and the least mature is that orangey tan color. That maturity model continues to reflect our standards development progress, regulatory adoption, and industry uptake and adoption of the specifications. Those three components are blended together to set the maturity level. But then within each maturity level that you may see there, you may notice that some of them the dials are still in a lighter color. There's an indicator here. If you can see, like, for example, here on member attribution, there's a little pointer there that helps you understand. And the lighter color stage reflects earlier stages of development in the sense of that we lather, rinse, repeat to mature our implementation guides. So when we've completed a ballot cycle and we're starting on the next version development, it'll be to the lighter phase color to the left. And then as we go into the darker phase colors, we are advancing our development, working our way towards or through connectathon testing, as well as the balloting process, reconciliation, and then ultimately going to be headed towards a publication phase. Our implementation guides are loosely organized into 4 categories. And I think what's really important is that for today, you're going to get an excellent overview of all of our implementation guides. And these are the use case specifications work that directly correlate to the value-based care pain points we seek to address as the Da Vinci Project to improve data exchange capabilities using FHIR, specifically in value-based care arrangements. The specifications produced enable software to come to life in support of reducing burden and improving overall efficiencies in support of achieving better patient outcomes. What I'd like to do is now pivot to our main event and invite Heras to come on screen, as she will be the first of our presenters. We'll then roll through each of our presenters, and then we'll take your questions at the end today. So please, throughout the session, put your questions into the Q&A box, and we look forward to addressing them at the end of the session. Yen?
Thank you. So first, I'm going to cover the notifications IG and a number of other use cases. Then I'll pass on to Lloyd to cover the remaining use cases. So the notification IG describes a method for communication of relevant notifications to support the real-time exchange of information that impacts of patient care and value-based or risk-based services. It also includes notifications about the changes in treatment, such as a new medication. Vinci published STU 1.1.0 update in April last year. So at a very high level, the changes made include updates to support multiple US core versions simultaneously, including US core 6.1.0 and 7.0.0. The changes also include alignment with the Direct Trust standard and the Vinci HRX STU 1.1.0 update. The notification use case now has a quarterly project calls. The next call will be the first Wednesday of March at 1 p.m. Eastern. We continue to looking for participation and implementation feedback and input from the community. So for this slide provides more details to the updates made in the published STU 1.1.0. Based on the Direct Trust community's feedback, the notification IG added a new cross mappings between the Direct Trust ADT message elements. So those are HL7 v2 data elements and their respective elements in the Vinci notifications ADT message bundle. It also included the direct ADT to Vinci notifications terminology mappings that maps the value set concepts between the two product families. So the update also addressed a number of comments received through JIRA since the STU1 publication. I won't go into the details here, but they are summarized on the slide for your reference. So the next use case I'm going to cover is the member attribution. So the member attribution IG, or often what's referred to as ATR, is a foundational asset that can be used across Vinci use cases. It provides ability for treating partners to establish and maintain a patient list. For example, if a provider needs to report quality measures for their patients based on the value-based contract, it is very important for them to have agreed upon and also accurate patient lists between providers and payers. SU2 was published in early 2024. It added member add, member remove, and confirm attribution list operations to provide payer and providers the capability to reconcile a patient list. It also created the Vinci data export operation to support bulk data export. In May last year, STU 2.1 was published. So this STU 2.1 update also added support for multiple US core versions. It also added the status of open to the attribution list status code system to support payer data exchange PDEX and the provider access API implementation. And discussions on the member attribution IG is now held monthly as a joint public call with the PDEX. So that's on Friday. And details of the calls are available on HL7, same as all the other Vinci calls. So the next slide I wanted to just first to, for everyone, so you're familiar with this term, the member attribution list data that is used in the ATR IG is to refer to the kind of data that are typically included for a member attribution list. So those data that are included are patient demographic data, data about the provider the patient is attributed to, for example, their MPI, TIN, and health plan data for the patient, like member ID and the plan name, and also some of the information about the attributions, such as attribution period, attribution list status. And so this diagram shows the data model that is used to define member attribution list data that is exchanged as part of the member attribution list. So as you can see on this diagram, so the ATR group profile is the main profile that is defined in this IG. So the next couple slides, I'll go over a couple of the typical example scenarios that are described in the member attribution IG. And this first scenario has been supported since ST1 publication. It describes a workflow that after payer and provider enter into a contract, a payer creates initial attribution list and makes it available to provider, and provider then reconciles the list with their internal data. If changes are needed, they will notify the payer, and payer will make changes to the list in their systems. The payer and provider can repeat this process until they agree on the list. They have an accurate list that they all agreed upon and finalize it for use by the provider. Then provider can retrieve the list and load data to different systems to support different use cases that they support, such as gaps in care and quality measures or PDEX. And the next scenario on the next slide, yes. So SU2 also added this capability to support this scenario. So provider has the option of creating the list in the payer system. Then payer adjusts the list internally and notify the provider with the changes. So provider could also request additional changes by using now the new operations that were added to STU2, so member add and member remove APIs to add and remove members from the list. Then again, so once a payer and provider agree upon a member attribution list, then provider can invoke the confirm attribution list operation to indicate there are no more changes to be made to the list. Then payer can mark or designate the list as final and make it available to provider for use. Provider may then use the Vinci data export using the bulk export process, getting the data for the list of patients in the member attribution list. So this slide summarizes the list of member attribution APIs defined in the guide, which includes a number of APIs to support ATR group discovery and reconciliations, and also bulk data request. So that's it for member attribution. So moving on to risk adjustment. The risk adjustment that this IG is focused on is the risk adjustment for revenue normalization, which is used to compare financial risk between populations. So risk adjustment models use hierarchical condition categories, HCCs, to predict future healthcare costs. And these models, such as CMS HCC, they group ICD codes into clinically and financially similar condition categories. And hierarchies then are applied to the condition categories to turn them into HCCs representing the most severe form of a disease. The risk adjustment IG was developed to really tackle the business challenge of improving the accuracy and the completeness of risk adjustment for revenue normalization. It standardizes the representation and exchange of risk adjustment condition categories and their supporting evidence. So the first version of the risk adjustment IG was published back in 2022. And the IG has since been rapidly adopted by many organizations and used in production. And those implementers have brought their implementation feedback and the new requirements back to the community by joining the public calls. So their input has been extremely valuable and is the key driver for the continued active growth of this implementation guide. And in 2025, Vinci published HTU2 and then later HTU 2.1. The 2.1 update supports multiple US core versions. And also at a high level, the risk adjustment IG provides the capability to standardize the exchange of HCC gaps and supporting evidence between payers and providers. It also provides a remark capability to add remarks, either coded remark or free text remarks to HCC gaps during the pre-visit planning chart review process, or the capability can also be used by providers at the point of care to provide feedback to payer. And most up-to-date or more accurate medical records could also be sent using the data exchange profile to close or invalidate gaps to help to really bring those HCC gaps or the diagnoses complete and accurate. And this year, we're planning for HTU3 ballot. So to participate, the project calls are held bi-weekly that are on Thursdays. The next call will be next Thursday, February the 5th. And this slide shows how the risk adjustment IG supports the standardized data exchange between payer and provider. So payer generates risk adjustment coding gap reports based on the data they have and using the standardized risk adjustment coding gap measure report profile, which is based on the measure report resource. And this report includes patient information, HCC gaps for the patient, the evidence status of the gap, whether the gaps are closed, open, invalid, or pending, and whether the gaps are historic gaps from the past or based on historical data, or suspected gaps from inference by suspecting engine. The report also contains other relevant information such as ICD codes for the HCC. It also has the capability to include clinical evidence that is used for generating the HCC gaps on the report. So payer can send the reports to provider, or provider can query the reports directly from the payer. And once the provider receives the report, they can evaluate the HCC gaps data that are shown on the report using their most current data in the EHR. If they see a gap that should be closed or corrected based on their latest information, then provider can then use the data exchange profile defined in the IG to send the medical record as evidence to payer. This interaction between the payer and provider really helps to drive more complete and accurate risk data being captured and shared. So remark is a capability that is added to HTU2 of the risk adjustment IG. Those are driven by use cases, business needs from the implementer communities. As part of the patient planning chart review process, a remark can now be added to HCC gaps. And also, as mentioned earlier, at the point of care, providers can also add their response to HCC gaps using remarks and provide the feedback back to a payer. A set of coded remarks were developed and harmonized based on real implementation needs. For example, providers may add a remark to the HCC gap and with the code saying assessed and not present to note that they have assessed the gap at the point of care when they sees the patient in office and the gap is no longer present. They could also note in progress if they are currently taking actions to address the gap. So this feedback can be sent back, provided back to the payer and to the entire feedback loop. The payer could also use the remarks to add notes about HCCs that they would like to share with the provider. So by adding this functionality, it greatly improves the communication between payer and provider about the HCC gaps, which could also help to lead more accurate implementation documentation on HCC and help you manage the patient's risk gaps more efficiently. So for the upcoming HTU3 ballot, we plan to include 2 new operations to support implementer needs. a new operation that enables requesting a risk adjustment coding gap report for a patient by providing a context ID. A gap report associated with the same context ID can be linked together. So the example that was brought forward was, for example, doing a pre-visit chart review, maybe a week before the patient's actual appointment. A gap report can be requested for the patient for that appointment. Then another gap report can be pulled, gathered during or after the encounter. Then this context ID may be a gap request ID, in this case, that is used by some systems to track appointment transitioning to encounter. So this can be used to link the gap reports together for example, utilization analysis. Another operation is to submit coding gap report with the condition category remarks along with the resources that are referenced by the remarks as a bundle. Because the structure of the remark extension is getting more complex, so we're providing this additional operation to help to submit the data. And this next use case I'm going to cover is a value-based performance reporting. The Vinci value-based performance reporting VBPR FHIR implementation guide is a standard way for payers and providers to exchange digital reports on how well providers are performing under value-based contracts. It makes it easy to share, and understand, and compare sources for quality, cost, and other goals, so everyone knows where they stand and what to work on. And by using one common format, payers and providers can track progress, earn incentives, and improve care together. And the VBPR IG standardizes payer-generated value-based performance reports that summarizes provider performance across different categories. So this includes lines of a business, that is whether it's commercial, Medicare or Medicaid, and different types of value-based contracts, payment models, financial metrics, quality measures, and and other data that you would like to include as part of the report. And this standardization of a payer-provider performance reporting for quality and risk contracts is crucial for healthcare systems and other provider organizations to receive timely interim reports to track and manage their performance on value-based contracts during the term, so they can improve their performance and see the incentives that they will be based on their performance during the year, instead of having to wait to the end of the year, which is late. So give them the opportunity to improve. The FHIR profiles specified in this IG are designed to combine quality performance and financial performance together. HL1 of this IG was first published in 2024, and HL 1.1 update was published last month to support US Core 6.1 and also DQM 5.0. DQM is a Da Vinci Data Exchange for Quality Measures IG, so the 5.0 is also based on US Core 6.1. And this HL 1.1 update also updated the subject the subject of the measure report profile to reference the ATR group. So you can now to say in the report that this report is for the group of patients that belong to this value-based contract. There are a lot of challenges with the current value-based performance reporting, and some of the major issues identified by the community are that there are lack of standardizations of the report formats among payers and for different value-based contracts. And that's true, especially for a lot of financial performance metrics. So there are a lot of variations on how those financial performance metrics are named and defined. And when a provider receives these performance reports from multiple payers for different contracts, it takes a lot of manual processes to harmonize and analyze their financial and quality performance. So they can make improvement before the end of the performance period, and those manual processes are also error prone, hence the need for developing this IG. And the VP-FHIR IG has 3 profiles. They are derived from the measure report and the measure resources. And the value-based performance measure report is the main report. It allows you to report on a list of performance metrics like revenue, medical costs per member per month, and associate each performance metric to a payment stream like shared savings, care coordination fee. If a value-based contract has a quality component, this measure report also allows you to bring in the quality measure reports using the evaluated resource element on the measure report. And the value-based performance quality measure report uses the existing DQM summary measure report profile by adding a few extensions. So you can additionally report data such as a star rating score for the measure. And the VBP measure profile is used to represent high-level information about the value-based contract. So this last slide for VPPR, we would like to show you some example data so that you may see in the value-based performance report that could be represented using this IG to get a better visual representation. And in this example, there are multiple payment stream like shared savings gated on quality incentive payments, and the care coordination fee. And the performance metrics included for each payment stream could be quite different. For the shared savings gated on quality, it has performance data on both financial and quality measures. And the performance reports can also show performance results stratified based on whether this is whether population is HMO, PPO, or by different regions within the provider organizations, or potentially other variables locally defined by the provider, or stratifying based on the combination of those variables. So having the ability to support stratification in the report is an important feature for performance analysis. And the VPPR profiles are designed, so we purposely or intentionally paid a lot of emphasis to design in a way that are flexible to support various different payment models and performance metrics. So even though if there are some new payment models or performance metrics that are not as named a code in the value set, the model itself, the profile itself has the flexibility to support those. And these payer-generated value-based performance reports are crucial because payers are generally the arbiters in determining financial performance on risk contracts with health systems. And we have providers that are actively looking for payers to partner with for testing and implementing this IG. So if you're interested or have the need for value-based performance report, we invite you to look into the IG and join the monthly call that is on Monday. And the current discussions are around integrating the use of a member attribution IG into the VBPR workflow. So the next use case is a data exchange for quality measure. So the DEQM is part of the quality measurement standards to support electronic quality measure reporting or digital quality measure reporting. And DEQM defines a number of measure report profiles to support creating measure reports for an individual, for a subject list, or creating an aggregated summary report. It also has a data exchange measure report profile to exchange data of interest for a quality measure. This IG also describes the use of submit data, collect data, and the data requirements, even though the latest development, some of these operations may be there are updates to them. when exchange data of interest for a measure, and the evaluate operation to calculate a measure. And additionally, DQM defines a care gaps operation, and you can use this operation to run care gaps reports for a patient or a group of patients using the patient list created by the member attribution IG against one or more measures. DQM published HL5 in May last year to support the QI Core 6, which aligns with US Core 6.1.0, and a FHIR quality reporting with the DQM track was held at the July 2025 CMS HL7 FHIR Connectathon, which really highlights the importance of this IG to play in the role of quality reporting when we move to using FHIR for ECQMs. And DQM was the first DaVinci IG use case, and also is the first IG that DaVinci handed the active development and the maintenance of the IG back to the community. The DQM related discussions are now being held at HL7 Clinical Quality Information Workgroup, CQI Workgroup. If you're looking to test the DQM IG in an upcoming Connectathon, it is covered under the clinical reasoning track. And DQM is expected to ballot again in May 2026. In this ballot, DQM will be balloted as a universal realm rather than US realm to support international adoption and implementation. So the update to the PSS, that is to change from US realm and to universal realm, that was approved. Okay, so the next one, and this diagram is just simply to show you where the DQM IG fits in the quality measure standards landscape. As you can see, DQM is on the lower right corner. It is the standard for measure reporting, and DQM uses QI Core as the standard. But once moving to the May ballot, I think since it's going to be a universal realm, so the dependency on the US realm-based QI Core will be removed from that ballot. Okay, so this is the last use case that I'm going to cover before passing it to Lloyd. This is the postable remittance, the remit. So postable remit is a relatively new use case that was launched in 2024. We're happy to report that SU 1.0.0 was published in April 2025. And this IG has a pretty focused use case. It creates FHIR APIs to retrieve a duplicate copy of a previously issued remit. The project calls will be held quarterly, and the next call is on March 3rd, Tuesday, 1 to 2 p.m. Eastern. The basic workflow for postable remittance is that a provider submits a claim to a payer or clearinghouse, and payer clearinghouse then returns adjudication determination to the provider. And there are times when a duplicate copy of the remit is needed in today's workflows. A provider would need to use portals or make phone calls to request a duplicate. And for missing remits, this usually triggers a manual intervention in revenue cycle workflow. Because for a variety of reasons, a single remit may need to go to multiple destination systems, but an 835 can only be delivered to one destination system, and the paper remit usually only has one payee address. So the postable remit use case can complement 835 EDI by bringing automation to the workflow. And the main benefits of having the postable remittance IG is to help automate the process of requesting a duplicate copy of a previously issued remit in real time. So that would remove most of the need for human interaction. Next one. So this IG has defined 3 operations for searching for remittance. And the scenario where a provider has a long outstanding claims submission without payment or remit, those are referred to as silent claims. So for silent claims, there are 2 APIs defined: search for a possible remittance by claim and search for possible remittance by patient. And lonely payment is when the provider has received the notification of the payment, but there's no remit accompanying the payment. So the search for possible remittance by payment operation can be used in this scenario. This IG also defines the 4th operation for downloading remittance. Thank you, everyone. I will now pass it to Lloyd for more DaVinci use cases.
All right. Thanks, Yan. As you can see, DaVinci has been busy. I'm going to start out by talking about HREX. HREX is an interesting implementation guide in that it's not intended to be implemented directly. Instead, it's a foundational guide for most, if not all, of the different guides that we provide. We're not doing a heck of a lot with HREX this year, but we are planning to do an SDU update in the next few weeks, actually. We're starting a public review on Friday, along with public review of a number of DaVinci guides. One of the features of the HREX implementation guide is that it allows us to look up what endpoints exist for a given payer. Because that's one of the challenges that EHRs have is they might know how to contact a given payer, but that doesn't necessarily tell them what the CRD endpoint is, the DTR endpoint, PDEX endpoints, etc. And we have a mechanism to do that. We're adding support for that to be version specific so that if a payer happens to support different endpoints for different versions, they can expose that. The guide also has common profiles across the different versions of US Core that we support. It has ability to do member match, which is leveraged by some of our other implementation guides. It provides guidance on subscription and polling and various other common things like shared expectations around security. And we probably will be looking at a refresh of the guide in next year as we look at refactoring some of the contents of our different guides and decide what should be shared and what shouldn't. Moving on, I want to talk about burden reduction. And burden reduction is a set of 3 guides with another one that plays a partial role. And those guides are all in support of the prior authorization process, plus some other things as well. We'll talk about that when we get to each of the guides. But what this does is it gives us an ability early in the process to talk from an EHR or other clinical system to a payer and say, hey, I'm ordering this thing. Is there information that I need to know related to, is it covered? Does it need prior auth? Is there documentation needed? What is the documentation that's needed? And then putting together prior authorization request if one is necessary, and having that all be FHIR based. And with CMS enforcement discretion, we no longer necessarily have to have X12 in the middle, although PASS does give us that as a mechanism for those that need it. And we actually have the ability to get prior authorization information back earlier. And then CDEX gives us this ability to supplement with missing information if a payer discovers that they need more after reviewing a claim. So that's sort of a high level of all of the different pieces, and then we're going to get down into more details. Next slide. So the notion of burden reduction is, everybody agrees that the authorization process is painful. It's painful for payers, it's painful for providers, And the notion behind all of the burden reduction guides is to reduce the effort on both sides. On the provider side, it's not ordering things that aren't covered if there's something that they could be ordering instead that is covered, because that means less back and forth with the patient. Trying to order something that the patient can't actually receive because they can't afford it isn't helpful to anybody. And so they can focus on interventions that are actually going to work for that particular patient. Also, there's often a lot of back and forth in terms of, well, now we need this answer, now we need this answer. And that requires the provider, when they are no longer in front of the patient, to try to recall what they were doing with that patient, try to recall answers to various clinical questions, and that's not super efficient either. And then, of course, there's a great deal of back office time spent trying to meet the requirements of different payers. On the payer side, there's a great deal of time spent looking at stuff, realizing you don't have everything that you need and asking for more. There's lots of manual review because the information they're receiving isn't necessarily as computable as it might be. Receiving CDA documents or worse, PDF documents doesn't necessarily make it super fast to find the relevant information. And so if we can get all of the right information available up front, and you might not even need to have a human review process because the information is sufficiently computable that you can just evaluate electronically, that makes everything so much more efficient. And so that's what we're trying to do with burden reduction, to make sure that the provider only has to put information in once. It can automatically flow into the data requests from the payer by populating their forms with existing data, et cetera. It makes life easier on both sides, saves money on both sides, and lets everyone put their attention where it belongs, which is making sure that the patient gets the most efficient and effective care as quickly as possible. Next. So obviously, I talked a lot about the benefits for providers and payers, but in the end, it's much better for patients because if they can get approval quickly, they can start their treatment more quickly. If there's a situation where what they are looking at possibly doing isn't covered or is going to require prior auth, and there might be a delay. They can talk about with their provider about what the other alternatives are. What is their plan B? If it turns out that approval isn't covered, they're not in a situation where they walk out of the clinic with an order and then get called back because it turns out that there's additional tests that are necessary for authorization that weren't done. They can have everything that all of the examinations that's necessary done before they leave, or at least have them all scheduled before they leave and understand exactly what's going on. Also, if they get discharged, they have a sense of there is going to be continuity of care because they've got the answers before they leave. On the provider side, everything that we can do to avoid providers spending their pajama time going through paperwork makes them a whole lot happier and reduces burnout. And also having the patients be happier makes providers happier. If a provider ends up calling a patient saying, hey, you need to come back because we need something for authorization, I mean, yes, the patient is annoyed at the payer, but they're also annoyed at the provider because why couldn't this have been done up front? And so everything time you can do that, it makes life easier. It also reduces the likelihood of information that's getting entered into payer portals not being accurate and having problems because of that, because the information ideally flows directly out of the EHR. And so long as the information in the EHR is correct, you don't have those transcription errors. On the payer side, we've got better documentation. So you've got documents that are actually tuned to what you need. You also have the ability to engage with providers at the time that they are ordering something. And so you can say, hey, you know that thing that you're ordering, it's not necessarily best practice, or you should be ordering this thing in addition, because that's going to help mitigate side effects. That's best practice. And so where the clinician is open to receiving that type of advice, and the system is set up to allow for it, you have that engagement mechanism much earlier in the process than you would have in a traditional environment where you don't know what's going on until a prior authorization request comes in. So let's get into the details of each of the different implementation guides. Coverage requirements discovery is built on a technology called CDS hooks. CDS hooks is a generic FHIR-based mechanism for decision support. And we are treating what's happening in CRD as decision support. Essentially, the clinician is doing what they normally do. They are not making a specific call to the payer. They're not even thinking about payment at this point. They are ordering a lab test or making a referral or booking an appointment or starting an encounter. And as they do their normal business process, capturing the information that they normally capture in the background, a request goes out to the payer that says, hey, here's what's happening. Here is the lab test that's being ordered, the imaging test that's being ordered, the doctor that's being referred to, here's the reason. And the request is essentially to the payer, do you have anything useful to share, particularly as it pertains to coverage? So is it covered? Does it need prior auth? Is there additional information that you need that you don't have? And as part of making that determination, the payer has the ability to go in and query the EHR for additional information with the permission of the EHR for this specific purpose. So if you need to check recent labs, if you need to check what medications they're on or what conditions they have that are active, you can do that. And then that information comes back and is displayed in the EHR in an EHR specific manner as appropriate for the workflow that's happening to inform the clinician about, hey, this thing that you're ordering isn't covered. Or congratulations, this thing that you're ordering is not only covered and needs prior auth, but the payer has determined that the authorization requirements have been met, and here's your auth number. And that just happens in the background magically without the clinician having to type a single keystroke more than they would normally have been typing. Furthermore, if it finds out that, hey, there's additional information that we need to have, because we couldn't get it all out of the EHR, we have some questions. It can give an indication of whether some of those questions require clinical input or patient input. And if the time in the visit allows, the clinician can opt to answer those questions right away and then be done. And of course, that makes the whole process flow much easier. And if the questions that come back are not clinician-facing questions, they have the ability to delegate those to back office staff if they so choose, or if they really want an answer right away, they can do that as well. So in terms of where we are at with CRD, we have been doing a lot of work over the last 8-ish months, dealing with feedback from our balloting process. We've gone through tons and tons of tickets, had very intense discussions with lots of representatives, and had really great cooperation from industry in trying to move the guides forward. We are going to be starting our public review period on the updates that came out of that ballot. There are some substantive changes to the guide resulting from those ballot feedback. And so we're doing another round, sort of a quick round of please take a look at our changes, make sure that you're comfortable that we applied things correctly, that we didn't break anything. And then we will be proceeding to publication. Expected publication date is sort of middle of March because we have to complete the public review, deal with any feedback, apply the changes, and then jump through HL7's publication process. In parallel with all of that feedback, we've been doing lots of work at connectathons, getting lots of implementers testing with each other. We had a really successful virtual connectathon a couple of weeks ago. And there's, as was mentioned, looks like we'll have another opportunity for a virtual Connectathon coming up in a few months. And so if you are working in this space, it'd be a great thing for you to engage with, to sort of see how your systems are going to play nicely with others. And of course, one of the other roles of our calls is answering questions. And so we're doing lots of that as people are working towards implementation. Moving on to the next implementation guide, documentation templates and rules, is essentially we have extra questions for you. Those questions might be related to determining prior authorization. They might be questions that you need to have answered when you eventually submit your claim. They could be questions that are relevant for just audit purposes to make sure that you're doing appropriate use, or questions that will need to be answered for a downstream performer because they will need it for one of these other purposes. And so having the ability to say, these are the questions that are pertinent to the order that you have. And there's sort of a few different ways that DTR can be triggered. It can be triggered by CRD saying, hey, there's forms that you need to fill out. You can invoke DTR directly if you don't have CRD available quite yet. And PATH, which we're going to talk about in a minute, also has the ability to say, hey, you've submitted a prior authorization request. After looking at the content that you've given us, we have further questions. And rather than just asking for particular LOINC codes for documents, there's a special code that they can send back that says, we would like you to invoke DTR. And so you can then ask questions. And the questions are expressed formally in FHIR, including the ability to specify where in the EHR you might be able to find these answers, if that information is likely to be exposed computably. And we have a couple of different mechanisms with DTR, either the ability to say, here's all the questions, fill them out, or also a back and forth mechanism where the payer can ask a few questions, get the answers, and then decide what they want to ask next, which is useful for certain types of payer workflows. And one of the advantages of that second workflow is when you finished answering all of the questions, it is possible for the payer to come back and say, you know what, you needed prior auth for this, but with the answers that you've given us, we've determined that you are authorized, and here's your authorization number. So again, it sort of bypasses some of that extra administrative process, at least in some circumstances. Obviously, there will still be some circumstances where you need to submit a formal prior authorization, where there may need to be human review. We're trying to reduce that as much as possible. And so by using these formal questionnaires and questionnaire responses, we have the ability to automate that back and forth, and make it easier for EHRs to gather that information without having to worry about portals, and being able to auto-populate stuff as opposed to trying to transcribe and dig through and try to figure out where that information might live in the clinical record. So in terms of DTR status, we are at a very similar point to CRD in that we have been going through tons and tons of feedback from the ballot, making good changes to clarify, enhance, and correct information within the implementation guide. We are working on exactly the same time frame. So again, a public review, hopefully opening on Friday for a little bit over 2 weeks for people to look at all of the changes that we've made. We do a pretty good job of tracking what is a breaking change, what's a substantive change, what are some of the non-substantive changes, so you can see all of that and then go look and see what we've done. And then once we get the feedback from that, we'll be moving toward publication in mid-March. And again, continuing to test, continuing to do connectathons, continuing to work with implementers as they have questions. And then next is PATH. This one is, we got to the point where you actually do need to submit a prior authorization. And so this is not generally clinician initiated. It's often initiated by back office staff, although it depends on the size of the practice, whether that's true or not. And you package up all of the relevant information, possibly including questionnaire bundles from DTR. And the data structures are fully aligned with X12. So information that you might have previously sent in a 278 and can still opt to send in a 278. You don't have to use pass. But if you opt to use the pass mechanism, you can express all of that using FHIR and use FHIR standard mechanisms to transfer that. We do have mappings, so if there's a situation where one of the parties wants to use FHIR and the other party wants to use X12, that's possible. We can translate back and forth. And we have the ability in relatively real time to send off a request and get back a response if the payer is able to adjudicate it that quickly. And if not, they can send back a response that pens certain things and says, I need to look at this further to make a decision. Or as mentioned previously, possibly say, I need more information because after looking at what you've given me, I realize that there's extra stuff that's now necessary. And so we have that mechanism available through PASS. In terms of where we are at with the project, actually, before I get to that, so I just wanted to flag the fact that we do have that ability to ask for additional information using CDEX, and this real-time mechanism might be dependent or actually give you an authorization sort of within a 15-second window. PASS, by the way, is the only place that you can get a denial. You cannot get a denial in CRD, you cannot get a denial in DTR, because in neither of those circumstances are you actually making a formal request for authorization. Only in PASS are you making a formal request. So CRD and DTR give you a mechanism of saying yes, but if you need to say no, you have to direct the provider to use PASS. And from there, when they've submitted all of the documentation in the formal mechanism, do you have the right to say, based on what you've given me, the answer is no, that's not covered. So again, where we're at with the project, we have doing exactly the same thing. We meet on all three guides simultaneously, CRD, DTR, and PASS. And timelines are the same. We're looking at going to public review on Friday for a little over 2 weeks, and then we'll be moving to publication and then ongoing support for the implementer community as they work towards the January 2027 deadline that CMS has set. Next implementation guide is CDEX. And this guide is tangentially tied to the burden reduction guides because we do leverage it, but it is not only for burden reduction. CDEX is a mechanism to ask a clinical system for documents or other information, RESTful information, FHIR information. And so that might be initiated as part of processing a prior authorization, but it could also be for a variety of other reasons. Maybe you need to close a gap. Maybe you are assessing a patient for particular coverage, whatever happens to make sense. If there is a need to ask for clinical information, CDEX gives you mechanisms to do that, and it provides a number of different mechanisms for that solicitation. So the next slide talks a little bit about that. We have the ability to just go and perform a RESTful query. So if there is a trust relationship between the EHR and the payer, and the EHR actually surfaces the information that is relevant over conditions or observations or some other endpoint, you can just query for that and get back the information that you need. There is also a mechanism where instead of just going and getting the data, you create a task for the EHR that says, this is the information that I would like to have. And then there is the potential for human intervention that looks at that and says, okay, we are comfortable with that, or we're not comfortable with that, or we're mostly comfortable with that. We'll package up the data, but we'll redact some of it. Or it might be that, yes, we have that data, but no, it's not available on the RESTful API. We need to go dig into a database, or somebody needs to dig into a paper chart and scan some stuff, whatever the case might be, to go find it and retrieve it. And so there is a mechanism to do things in an automated fashion. There's also a mechanism to do things with either practitioner or back office intervention to gather the information that's necessary. So if we want to look at the use cases for CDEX, we can use it to send attachments, whether that's for claims or for prior authorization. We can ask for supporting information, whether that's for audit or quality reporting, closing gaps, etc. We can pass information between a referring provider and who they're being referred to. And CDEX does have a mechanism to electronically sign data if that happens to be a requirement, and the infrastructure is in place for doing that. In terms of where we're at with CDEX, we've had a little bit of feedback on CDEX, but it hasn't been enough for us to justify creating a new release of it yet. So we're going to continue to rely on the existing release of CDEX for the next little while. We will continue to, of course, to provide implementer support and look to have people participate in connectathons exercising the CDEX specification, both in use with burden reduction, but also in use for other purposes. Depending on the level of feedback that we get, we may look at doing a ballot at some point in the future, but probably not until next year. All right, that was all burden reduction related stuff. So if we move past that, the next topic is PDEX, and that is similar to CDEX. This stands for Provider Data Exchange, or sorry, payer data exchange. And this is a situation where a payer has information that needs to be made available to others. And there's a number of different use cases. The first of them is, how do you expose information to patients? And we've got a few different types of information that we want to be able to expose. Obviously, there's the Karen Blue Button standard that provides information about claims and prior authorizations and that sort of stuff. But we also have use cases for exposing formulary. So what is covered in terms of drugs by this particular plan versus not. And also the ability to go and look at other data that the payer might have that the patient is interested in having access to. The next type is access to payer data by providers. And the reality is that in many cases, a payer will have a more complete picture of what's going on with a patient than a provider might, because most of the interventions that happen with a patient, regardless of where they're delivered, end up flowing to the payer because they pay for them. Whereas a given provider only sees the patient for the interventions that they're actually getting there. And so a payer may be aware of additional medications, immunizations, lab tests, or the lack thereof that are relevant for that particular patient. And it is useful for providers to be able to access that information, and it's useful for payers to ensure that that information is available so that good decisions are being made about the care of their patient, and hopefully the costs for those patients are being kept down. And so we've got a couple of different ways of doing that, either direct query or bulk retrieval, where we just on a regular basis say, this is a patient or this is a set of patients of ours, please give us net new stuff that you are aware of that is related to them so that we can incorporate that in our records. So from an architectural perspective, we have payer data that may come from claims process or prior authorization process, may also be submitted by other mechanisms. And then we have a mechanism for that data to flow into or back to clinical systems based on what they know. So we can share a wide range of information about different types of resources. Some of those are, of course, exposed over the Blue Button API. Others are exposed over either the bulk access or the provider access APIs. So in terms of using the provider access, one of the key considerations, which of course relates to the guide that Jan was talking about earlier, is you need to have attribution before a clinician can say, hey, can you tell me information about patient John Smith? The payer needs to understand that there's actually a clinical relationship there because we don't want a provider just saying, hey, tell me information about people that I might be able to recruit to be my patients. That would not be okay. And so we need to have mechanisms to establish how do we know that a patient is in fact a patient of a given provider organization. And so you can know that by the fact that, well, we received a claim from this organization for services rendered that kind of suggests that this patient is indeed a patient of them. But we can also do that with other mechanisms. So in CRD, if we receive a CRD call that, hey, we're booking an appointment for this patient, or we're ordering something for this patient, or we're starting an encounter with this patient, that is a clear indicator that, okay, there is a relationship. And once that exists, you can then enable the ability to query for data. The payer may also have other attribution rules. And of course, we have the attribution guide to enable that sort of thing as well. One of the other reasons for accessing data, in addition to patient and provider, is payers accessing other payer information. Sometimes you will have a patient that is transitioning from one plan to another, held by a different payer. And so you want to ensure that that data flows so that, first of all, you're able to maintain appropriate levels of care for the patient. You know what has already been approved, you know what medications they're already on, you know what lab tests have been done, and so you can make appropriate decisions about authorizing new things and covering new things. And so we have a specific mechanism to match members between one payer and another. So that's building on the HREX member match and allowing that to occur between payers, but also allowing that to happen in bulk. So you can say, here's a bunch of members of my plan, and I believe they all have coverage with you, and here's the information that I know about the coverage with you. Can you please sync those up? And then some of them you will match and you will say, yeah, I found them. I know who they are. Other times you'll say, well, this could be one of 5 people and that's not enough for me to give you information, so I need more. There is also the possibility of sharing consent. So you can actually have a patient authorize the ability to flow from old payer to new and track the documentation of that. So in terms of where we're, I guess we need to talk about formulary as well. So formulary is about surfacing information from a payer about what it is that they cover. And the notion here is not tell me everything that you cover. It is, I am currently taking these 4 meds. What coverage do you have for those things? So it's not surfacing the entire definition of the coverage. It's, I'm interested in these specific questions. What are the ramifications if I were to move to your plan? in terms of you covering the things that I happened to uh, need or believe that I'm likely to need over the coming plan period. And then we also have a mechanism to say, to drill into different plans and ask that same question about the different plans that might be available from a particular payer. And the idea here is that patients and providers want to know what is going to be covered, both when choosing a plan, but also when exploring the possibility of different medications. Being able to look those up is a helpful thing. So again, this can happen in a synchronous manner, or it can happen, moving on to a different one. So this is provider directory. So this is the ability to figure out who providers are. And that's a key part of making a lot of these other things flow. Is in order to, say, call CDEX to get information from a provider, you need to be able to find that provider and find what endpoints they have for interoperability. And so we have a standard for being able to access what providers exist, what organizations are associated with, and what endpoints are associated with them. And we are aligning the work in the PDEX implementation guide with the FAST National Directory, which is being coordinated with CMS. And so we're expecting to be able to leverage that. In terms of where we are at with PDEX, PDEX is also looking at doing a new release for the base PDEX guide in the relatively near future. They are also adjusting what their primary security authorization mechanism is, moving from mutual TLS to using UDAP. And as with everything else, they are testing actively both at Connectathon and between, and responding to feedback from the community as that feedback comes in. Next implementation guide is sort of a what did we do? Because we are sort of declaring victory on this one. This was a sort of quick project that was driven by the burden reduction initiatives and specifically DTR. One of the things with DTR in terms of its ability to populate questions with data from the EHR is that it uses CQL, which is a language that is used to access and manipulate FHIR data and lets you write relatively complex logic. And as the payers started to get into working with it, they said, you know what? This is complicated, and it would be oh so nice if there were some reusable chunks of CQL that we could all just leverage that did some of the harder things for us. And that's things like we are supporting or accessing US core interfaces, but those US core interfaces vary because there's different versions of them and different EHR support different versions, but also there's optionality. And we want to have the flexibility to get the specific data that we need, regardless of what search parameters might be supported by a given endpoint or not. And so if you could make that transparent to us to do the filtering for us, if the search doesn't do that, that would be helpful. So we started this in 2024. Next slide. And basically asked the implementer community what would be helpful. And so they said, well, it would be useful if we had functions that did this and this and this. We got feedback, and took that feedback and then went to the Da Vinci operating committee, and they said, yeah, it's reasonable to do a quick project to get some initial artifacts in place to make that work. And so we started that in mid-2024. And basically met for a year, put together an implementation guide that addressed those things. So what were the best practices in terms of tools? What are some shared libraries that everyone can use? What is best practices for writing CQL and having it not blow up and work well? And work reliably across a variety of different engines that different payers might use. And then also wrote some shared CQL functions and libraries that are not mandated for use, but that implementers are certainly encouraged to use because that would A, save them time, B, make it more likely that their queries are more robust than they otherwise would be, and also help them to avoid some of the gotchas that may exist in accessing data and or CQL use. So in terms of where we are at, the implementation guide is published. And because it was a quick hurry up project of let's make this happen and get it available for implementers, we do not anticipate ongoing work, at least in terms of funded by Vinci on this. The implementation guide is now owned by the Clinical Decision Support Work Group, and they will maintain it on a go-forward basis. So it's not that it's locked and will never change, but Vinci's role in sort of getting it up and running and out the door is now considered complete, and we have declared victory on it. And that's enough of me talking. We'll now transition to Casey, who will fill you in on the remaining Vinci implementation guide.
Thank you so much, Lloyd. Thank you all for being here today. Hello, my name is Casey Thompson, and you're near the end of our presentation today, so hang in there for a little bit longer. Again, my name is Casey Thompson. I'm a nurse clinical informaticist and the program coordinator for the Vinci project, and very happy to be here today. So thanks for having me. Okay, let's talk about patient cost transparency real quick. So Vinci members identified patient cost transparency as an opportunity to improve payer-provider data exchange back in 2019. And in 2021, the scope of the use case became more focused on a component of the No Surprises Act. So the No Surprises Act helps protect patients from surprise bills, which can cause medical debt and bankruptcy. So the whole point of PCT is simple. It helps patients avoid unexpected medical bills and make informed decisions about their care. And the latest published version is STU2, published in October of 2025, has a lot of key updates as shared on this slide. And looking ahead, there's some small technical corrections that are being made to address technical issues, and we're expecting further regulation to continue shaping this work, so keep an eye out for that. Now, the big improvement in this new version of the implementation guide is that it lays out a clear workflow for notifying all of the providers involved in a patient's care during a period of time. So that way everyone can contribute a portion to the good faith estimate, and the full set of expected items and services can be submitted together. The payer then receives all the information and can process this estimate using the patient's coverage and benefits. And using a FHIR-based approach, the payer can return the AEOB to the patient through FHIR APIs, giving patients more options on how they receive and review their information instead of just paper, right? Wouldn't you like to have that information through an API? Of course, not every situation is this complex, so the IG covers a simpler use case too, just one billing provider. But that makes it easy to generate the GFE and get an AEOB without all the extra steps. Yeah, so Vinci has a pilot opportunity with patient cost transparency, and the PCT started their pilot in 2025, and we're open to organizations interested in piloting so we can further advance the guide and validate real-world workflow and technical challenges. So if your organization is a payer, a provider, or healthcare technology company, we would love for you to join our use case calls, or you can reach out to us using the email on the slide to participate in our pilot. And it's important to note that our next community roundtable in February plans to focus on PCT and may have some of these pilot organizations there to share their work and their progress so far. So that's a great chance to get more information about PCT and pilots. Okay, another key pilot effort we have is the Trebuchet Pilot Initiative. Now, our specifications only get better when they're used in the real world, when we implement, learn from the experience, and improve the guides based on what we've learned. So that's the goal of our pilot projects. The Trebuchet FHIR pilots began in 2024, and we continue to expand and improve them and strengthen them going into 2026. The goal is to help payers and providers implement Da Vinci implementation guides and move them into production ahead of compliance deadlines. We also build resources to support implementers, including educational materials, lessons learned, and a community to practice and where people can discuss their implementation experiences. So the Trebuchet project focuses on creating a connected network-based approach for payer-provider data exchange, recognizing that we now have TEFCA and QHINs and CMS-aligned networks and others, which give payers and providers the ability to connect to many partners through a single network. But at the same time, Trebuchet also supports more direct one-to-one connections between payers and providers when that's the better fit. Okay, so learn more and get involved. The Trebuchet project, just like all of our projects, is all about learning from each other as we implement. So we want to grow the community and bring in more implementers who want to build their FHIR expertise. And anyone can join the biweekly calls, and there's no cost to participate either in the calls or the pilot. And there's a Trebuchet cohort sign-up page on this slide if you're interested in joining a cohort or learning more. Really encourage you to get involved. Okay, the next slide here, yes, this call to action slide. It's packed with helpful information about Da Vinci, everything you need to know about how it works and how to plug in and get involved. There's our implementer support page, our Da Vinci interaction page, and other Confluence pages on this slide. So really encourage you to look at that implementer support page in particular if you get a chance. And our use case call schedule. So please join our calls. You can find all of these calls in the HL7 Conference Call Center, a link with how to add these calls to your calendar. You can reach out to us at the email if you have any questions and sign up for Community Roundtable and updates. And I think we're at time, Alix. But we have a lot of good resources on this slide as well.
We sure are at time. This has been such an amazing session with lots of great information. And Casey, you did a fantastic job on bringing us home. So with that said, I want to respect everyone's day has been long and probably have more things that you still need to do today. So we're grateful that you were here. There will be a survey at the end of that'll launch at the end of this webinar. And we look forward to seeing you at a future session. And if you need to reach out to us, you can find these slides on Confluence with our contact information. And thank you for participating in today's combined Community Roundtable and Birds of a Feather. Thanks. Have a great day.